pancreas secretes boluses of insulin at high doses in response to meal. So this is to reduce the glucose surge or to reduce the spike in the blood glucose level after meals. But in between meals and overnight, the pancreas secretes small amount of insulin continuously, and this helps in maintaining the blood glucose level in the normal range, promote utilization of glucose by various tissues, and reduces glucose output by the liver. So this helps to maintain the blood glucose level in the normal range, and this is known as basal insulin. In a diabetic individual, there is deficiency of insulin, and this results in derangement of carbohydrate metabolism, leading to hyperglycemia. So a physiologic insulin regimen has been designed to mimic the natural pattern of insulin secretion and is useful for the treatment of diabetes. This regimen is known as Basal Bolus Insulin therapy and is used in the treatment of type 1 and type 2 diabetes mellitus. So what are the different types of insulin that are available and can be used for the treatment of diabetes? The various types of insulin can be classified based on the onset of action, peak effect, and duration of action. The types of insulin can be classified as rapid acting, short acting, intermediate acting, and long acting insulin. The rapid acting insulins include insulin Lispro, Aspart, and Blue Lysine. The regular insulin is a short acting insulin. Intermediate acting insulin is NPH or neutral protamine hacked on. This is also known as isophane insulin suspension. In long acting insulin category, we have insulin glargine, insulin detamers, and insulin degludec. So now that we have learned about the various types of insulin that are available in the market, how do you select the insulin type for basal bolus insulin therapy for the management of diabetes? So for bolus therapy, insulin analogs or regular insulin can be used, but comparing insulin analogs with the regular insulin, the insulin analogs are preferred over regular insulins for bolus therapy in the management of diabetes. The reasons being insulin analogs are rapid acting insulins. Given at meals, the onset of action is less than 15 minutes. So it closely matches the body's natural pattern of insulin secretion. It provides more efficient postprandial blood glucose utilization, and because the duration of action is short, it helps in reducing the risk of late postprandial hypoglycemia. So the risk of hypoglycemia is less with that of insulin analogs because the duration of action is short. Also, the insulin analogs are more consistent in the action. The action is more predictable because the absorption is not affected by the injection site, dose, and exercise, unlike regular insulin where there is a variation in absorption depending on the exercise and the injection site and dose. Therefore, insulin analogs are preferred over regular insulins for bolus therapy. So you can check out my previous video where I have discussed in details about the short acting insulins. Today I am going to discuss about the intermediate acting insulin, that is NPH, and long acting insulin such as insulin glargine, detamers, and degludec. So let us now move on to discuss NPH, which is an intermediate acting insulin, and long acting insulin such as insulin glargine, detamers, and degludec. So NPH also stands for neutral protamine hacked on, also known as isophane insulin suspension. It starts in 1 to 3 hours and the peak effect occurs in 4 to 12 hours. Whereas for long-acting insulins, they start in 1 to 2 hours but the duration of action is prolonged. It is approximately 24 hours, and for degludec, it is even more than 42 hours. So both NPH insulin and the long-acting insulin serve as basal insulin therapy for the management of diabetes. NPH can be administered subcutaneously twice daily, and it helps to maintain the blood glucose level in the normal range in between meals and overnight. However, a limitation of NPH is that the patients may have a variable pattern of response with time, and those with higher doses of NPH may have later peak and a longer duration of action, and this can increase the risk of hypoglycemia. There are day-to-day fluctuations in blood glucose responses with NPH, and this is due to variation in absorption of NPH. So these drawbacks can be overcome by using long-acting insulin such as insulin glargine, detamers, or degludec. So these insulins have less pronounced peak compared to NPH, and the duration of action is prolonged for about 24 hours. For degludec, it is more than 42 hours. So speaking about insulin glargine, which is a long-acting insulin, what are the structural changes that makes glargine a long-acting insulin? As we know that insulin is a protein hormone consisting of two peptide chains, the A chain and B chain. The A chain consisting of 21 amino acid long and B chain consisting of 30 amino acid long. In case of insulin glargine, there is a change in the amino acid sequence where asparagine in position A21 is replaced with glycine and two arginine residues are added to the last amino acid in the B chain. So if you look at the word glargine and break it into GL and arginine, glycine replaces asparagine at position A21 and two arginine residues added to the last amino acid of the B chain. So this creates glargine, which is a long-acting, which has a prolonged duration of action. So because of the modification in the amino acid sequencing, glargine becomes soluble in acidic pH. So it is available as a clear solution at pH 4, and once injected, it comes in contact with physiologic pH, it precipitates, it forms clumps, it forms a depot from which insulin is slowly released into the circulation with a prolonged duration of action of approximately 24 hours. The addition of zinc further prolongs the duration of action of glargine. Therefore, insulin glargine has a less pronounced peak compared to that of NPH. It is also known as peakless insulin because it does not have a peak. It provides a steady concentration of insulin overnight and in between meals irrespective of the food intake, and this serves as basal insulin, helps to maintain the blood glucose level in the normal range. It is approved for once daily subcutaneous injection and it can be taken at any time during the day, but it is important to take it at the same time each day. The next long-acting insulin is insulin dekimer, where the duration of action is more than 24 hours. So how is insulin dekimer different from that of insulin glargine? So if you look at the structure of insulin dekimer, a fatty acid moiety is attached to the last amino acid, and because of the attachment of fatty acid, the duration of action is prolonged to more than 24 hours. Because the fatty acid gets attached, it binds to albumin and this releases insulin slowly into the circulation. There is slow absorption of insulin into the circulation and resulting in prolonged duration of action. As you can see in this figure, threonine at position 30 is removed and 14 carbon fatty acid is attached to the lysine residue at position B29. So this makes dekimer a long-acting insulin acting for more than 24 hours. It is approved for once daily subcutaneous administration. So the next long-acting insulin is insulin degludec with a duration of action of more than 42 hours. In terms of structural modifications of degludec, threonine at position B30 is omitted and glutamic acid and a 16 carbon fatty acid is attached to the last amino acid in B chain, and this makes degludec a long-acting insulin of more than 42 hours. So both insulin dekimer and insulin degludec have fatty acid moiety attached to the last amino acid of the B chain, and this makes these insulin long-acting insulins and they provide basal insulin coverage for the treatment of diabetes mellitus. Apart from this, we also have insulin combinations where NPH is combined with insulin analog or regular insulin, and this helps to provide both bolus and basal insulin therapy. Some of the common insulin regimens that are employed for the management of diabetes are: firstly, 2 morning injections of rapid-acting or short-acting insulins can be combined with intermediate-acting insulin. The second type of insulin regimen is morning injection of rapid-acting or short-acting insulin, pre-dinner injection of rapid-acting or short-acting insulin, and an intermediate-acting insulin is given at bedtime. This is particularly suggested for patients with early morning hypoglycemia or rebound hyperglycemia resulting from hypoglycemia during the night time. So bedtime injection of a long-acting insulin helps to maintain the coverage and prevents early morning hyperglycemia. The third type of insulin regimen is pre-meal injection of rapid-acting or short-acting insulin and combining with a long-acting insulin administered at any time during the day. So we have learned about the various types of insulin, the short-acting insulin, the long-acting insulin, how they can be combined for basal bolus insulin therapy and the different combination insulins. So thank you for watching. If you find my video useful, please like and subscribe to my channel.